Now coming to the GI motility. This motility is very, very important. In GI motility, first, like we saw it in CVS or other systems also, there should be something to generate the electrical wave. Then followed by that, only mechanical action will come. So it is always the electrical event which happens first. And the electrical event in GIT, it is called as BER. What is this BER? It is called as basal electrical rhythm. At the base, whatever electrical activity is called as BER, basal electrical rhythm. This basal electrical rhythm, it is like the RMP for the GIT. It is nothing but the resting membrane potential of the GIT. So this GIT, it's not having one specific value of RMP. RMP of the neuron we saw, it is around minus 70. But here it is not one value. It is fluctuating between different values. It is fluctuating in between minus 65 and minus 45. It is constantly moving around these two values, minus 65 to minus 45, and it is constantly fluctuating. And here there is a phase of depolarization and the phase of repolarization, like we saw it in the other neuronal action potential also. So what is the reason for the depolarization part? The entry of calcium ions. The calcium ions, here we should pay attention because we saw the sodium ions are responsible for neuronal depolarization, whereas here it is the calcium ions. So this calcium ions is the one which is causing the depolarization wave or the upward wave, depolarization. Then which is the one which is causing depolarization, repolarization in case of a GIT? It is again the potassium. Even in the neuronal cells we saw it is potassium. In GIT also it is potassium. The repolarization part is by the potassium. So both are potassium. This is a spontaneous rhythm. It is not someone has to induce it or some action potential has to come and reach it to stimulate these RMP. It is constantly fluctuating. The basal rhythm is always there. It is constantly fluctuating. This spontaneous rhythm is generated by a pacemaker cells. This pacemaker cells is called as the interstitial cells of Kajal. Interstitial cells of Kajal is the one which is producing this pacemaker kind of activity or basal electrical rhythm. Once they have asked the exact location of this interstitial cells of Kajal, it is exactly located in the circular muscle layer. Circular layer is inner or outer? We just saw it right now. It is the inner circular layer. So it is the inner circular layer. And especially it is starting from the proximal body of the stomach. Proximal body of the stomach. And this is maximally produced in one region, that is the duodenum and jejunum, and it is least produced in the ileum. So this is all about the basal electrical activity. Can a basal electrical activity generate contraction? The answer is no. It does not generate any type of contractions. So someone has to help it to produce a contraction. It does not generate any contraction. So whenever any impulse comes in, then it will sustain a spike potential. So what is this spike potential? So whenever any other impulse is coming, suppose the first one is the basal electrical activity, the above one shows here. So whenever any impulse comes, for example, let's take what is the most important neurotransmitter for peristalsis or any movement in GIT? It is the acetylcholine. Acetylcholine. Whenever acetylcholine comes and activate this basal electrical activity, what it will do is it will generate something like this, a lot of potential. This is called as the spike potential. This is called as the spike potential. So what happens whenever there is a spike potential generated? The muscle which will be in the state of rest now will start showing the movement. Suppose the movement of muscle is recorded, it will show a contraction movement. So it is showing a contraction movement whenever there is a presence of acetylcholine. Can it relax? In a similar manner, the basal electrical activity, whenever it is inhibited by some substances, for example, let's take epinephrine. It is a sympathetic system. Epinephrine, whenever it is there, what will happen? The muscle which is already in a slight contraction, now it is going in for a relaxation. It will go in for a relaxation. So this is what happens in the spike potential and the basal electrical activity. So once the basal electrical activity is superseded by some of the enzymes or any neurotransmitter, it can produce contraction. Whenever contraction starts, we get some mechanical activity. What is that mechanical activities in the GIT? Some type of mechanical activity happens during the fed state. Suppose we are eating and during the fed state, or the person is having food in the stomach, during the fed state, this is going to happen. And few events, some motility is present even in the fasting state. This is important. Even if somebody is fasting, even if somebody is having a long hour of gap between meals, then also some motility is happening. Let's see what is that motility. So coming to the fed state, we have two important motility. One is the peristalsis and another one is segmentation. Now the question comes, among the fed state, which is the most dominant motility? What is your answer? Most of you will answer it as peristalsis, but that is not the correct answer. It is absolutely a wrong answer. The dominant motility in a fed state is nothing but segmentation. It is the dominant motility. And many tend to make mistake in this question. That's why it is being asked. Dominant motility during a fed state is segmentation. We'll try to understand why this segmentation is dominant. Then coming to the fasting state, in fasting state there is one type of motility which is called as MMC. MMC is nothing but the migratory motor complex. This migratory motor complex is also important thing to study. Migratory motor complex. So what happens in peristalsis? Let's begin with peristalsis. So what happens in peristalsis? Peristalsis is the wave which is produced from the oroanal direction. From the oral cavity, the food is being passed to the anal segments with the help of peristalsis. So what does it mean? It is basically moving food from one segment to the next segment. It is moving the food from one segment to the next segment. This is called as propulsive movement. Propulsive means it is propulsing the food to one segment to another segment. So peristalsis is a kind of propulsive movement. So how does this peristalsis happen? And all the neurotransmitter that we are going to study in next 2 minutes is important. All of them are MCQs. All of them are MCQs. So first thing is, whenever food is there, it will stretch that part of the stomach because it is a lumen and some object is there. It is going to stretch it. So whenever the food is there in the stomach, it is going to be stretched. This stretch will activate what type of neurons? Stretch will be sensed by the muscles. And what is the plexus present in the muscles? It is our myenteric plexus. So our myenteric plexus will get activated. And this myenteric plexus at that region will produce one neurotransmitter which many of you fail to learn. That is the neurotransmitter here is serotonin. Serotonin is the neurotransmitter which is released at the site of the stretch. This is very, very important. I am stressing it again and again. At the site of the stretch, serotonin is released. So once serotonin is released, what it is going to do? It is going to send impulses forward as well as backward. So first thing is, it is sending impulses to the proximal side. Proximal side means behind the food. Then distal means ahead of the food. So now ideally this food has to move in this direction. Let's take. So what it is doing, it is sending the impulse to the proximal side. Proximal side, what do I want? I need some contraction. So if I contract the proximal side, what is going to happen? The food is going to be propelled. So proximal side, we need contraction. That is clear. But what is the neurotransmitter? That is the question. What is the neurotransmitter that is acting in the proximal side? All of us know one neurotransmitter that is causing the contraction, that is acetylcholine. But sometimes they don't give acetylcholine in the option at all. What is this next option? Next option is substance P. Substance P is the second option that is causing the contraction. Next, some of the impulses are going forward, like in the distal movement. Distal, what I have to do? Food is coming in, I should relax the segment. So distal segment is going to get relaxed. So it is causing a relaxation. But the question here is, what is the neurotransmitter involved in this? There are three neurotransmitters, all three we have to remember. ADP is not a VIP. Just remember, ADP is not a VIP. ADP is one neurotransmitter. Then NOT means it is no. NO is nitrous oxide and VIP is vasoactive intestinal peptide. NO is nitric oxide and VIP is vasoactive intestinal peptide. So these are the three neurotransmitters which is causing the relaxation. So first stretch, serotonin, which is behind contracting, ACH and substance P, which is relaxing in the forward, that is ADP, NO and VIP. All these neurotransmitters are important. Then the peristalsis happens in the large intestine also, and there it is called as mass movement. And there is one reflex which is called as gastrocolic reflex. What happens with some children and even in some adults, whenever they eat, they want to go to the for defecation. They want to go to the restroom and defecate. What is the reason behind it? Because there is some mass movement that will happen because of the gastrocolic reflex. Gastric side, the food is received, or in the stomach, the food is received. It will stimulate this mass movement in the large intestine. So what will happen? Defecation immediately after the meals will be followed. This is more predominant in case of children because their reflexes are not yet well developed. So children, this is very common. And this mass movement, maximum movement happens in the sigmoid colon. This is also asked once. It is in the sigmoid followed by the transverse colon. So sigmoid is a better option. Go for sigmoid colon. Then this is all about the peristalsis. Now coming to the dominant motility, we said it's not the peristalsis, it is the segmentation. Now coming to the dominant motility, that is segmentation. What is segmentation? Peristalsis was a propulsive movement. It was moving food from one segment to the next segment. But here it is not going to move to the food to the next segment. What it is going to do is it is going to attack the food from all sides. Contraction from all four directions will happen. See here, we have drawn it like contraction from all sides will happen. That is segmentation. It will take the food in a particular segment and start to churn it and then melt it. Like it is like breaking the food like anything. Okay. Here it is a non-propulsive movement. The food is not broken. So why this movement has to be a dominant motility? Why? Because we need the food to be churned and absorbed all the nutrients from the food. If the peristalsis is a dominant movement, what it will do? It will just propulse the food to the from the oral to the anal cavity. There will be no real absorption. And of course, GIC's major function is to absorb the nutrients from the food. So that's why this motility is dominant and it takes a large amount of time, and it is the time required for digestion as well as absorption. Then there is some special type of motility in the stomach. Whenever food is there in the mouth itself, the stomach starts to dilate. It is a kind of feed forward mechanism we saw. So this is called as receptive relaxation. Receptive relaxation is relaxation on the sight of food. Just by seeing the food or just by keeping the food in the mouth itself, the stomach is going to dilate. And there is something called as adaptive relaxation. What is this adaptive relaxation? Whenever the food reaches the stomach and it is dilating, then that becomes adaptive relaxation. If the food is reaching it and the stomach is dilating, then it becomes adaptive relaxation. This is all the motility in the fed state. Now coming to the fasting state. In the fasting state, we saw some motility. What is that motility? It is nothing but our migratory motor complex. First of all, why do we need motility in case of fasting state? Ideally, it's not required, but the food materials which are getting stuck up in the GIT, they have to be propelled, and it has to be cleaned during every movement. That is the reason why we need this kind of movement during the fasting state also. So what happens here? Here the hormone, one important hormone is involved, which is called as motilin. This hormone is called as motilin. This motilin is the one which is creating this kind of movement. So what it does is it is produced by the MO cells of the stomach. This MO cells of the stomach is doing this kind of motility. These are minute contracts in the GIT which is propelling the food, that food remnants from the stomach during a fasting state. What is the function? Its function is like a housekeeping job. Housekeeping job. It is like cleaning the house. It is like cleaning the house. It is cleaning the GIT. For cleaning the house, first thing is we'll do the broom. So movement is required. At the same time, we do it with the mop also, like washing it away. So even in the fasting state, the gastric juice is produced. Even in the migratory motor complex, the gastric juice is produced. Why gastric juice has to be produced? It will help for more cleaning of the stomach. So the gastric juice is produced even in the fasting state. And after how long it happens? This happens 90 to 120 minutes after a meal. That is why people advise not to eat junks in between, because you need this amount of time span for the stomach to be completely clean. If somebody is eating in between this immediately after food also, what will happen? Their migratory motor complex will be abolished. And even during the fasting time, for every 90 minutes once, it is going to produce this type of migratory motor complex. Now this is all about the motility during fasting and fed state. Coming to the motility disorders. there are very much important two motility disorders. One is the achalasia cardia, another one is Hirschsprung's disease. So let's try to understand what is the defect in each of them. First, coming to achalasia cardia, what is the defect? Here the lower esophageal sphincter is not relaxing. Ideally, whenever the food is coming, the lower esophageal sphincter should relax, then only it can enter the stomach. So it is not relaxing. What is the problem? Hirschsprung's disease. Hirschsprung's disease is also called as aganglionic megacolon. Here, the ganglion cells itself is not there. Aganglionic megacolon. So, what is the problem in case of achalasia cardia? The achalasia cardia, there is increased amount of ACH production. So, it is contracting the lower esophageal sphincter very strongly and not allowing the food. So, what will happen? More and more food will start accumulating above it. And there is one beautiful sign in radiologically which is done with the help of barium enema, and we could see a bird beak appearance. Bird beak appearance. Why this is happening? Because of the failure of the lower esophageal sphincter. So the center is not relaxing. This area will be constricted and the food will be accumulating above. So it looks like this region looks like a bird beak. That's why it is called as bird beak appearance in barium enema meal. So what is the treatment for this? We have to ideally reduce the amount of acetylcholine that is being produced at the lower esophageal sphincter. Here we can use one toxic substances actually, but in very minute doses. That is called as Botox. Botox is nothing but the botulinum toxin. This botulinum toxin is being used for facial also to reduce the wrinkles and everything, as a beauty product also, but this dose should be very minimal, otherwise it is a severe toxin, the person will die. So this botulinum toxin is given. What it will do is, its function is to inhibit the ACH fusion. ACH has to fuse with the postsynaptic membrane and it has to be released. So if it is blocked, what will happen? The amount of ACH will get reduced. There is a decrease in ACH and there will be a relaxation of the esophageal sphincter. Otherwise, there is one more surgery which can be done, which is called as Heller's myotomy. Heller's myotomy. These are the treatment options for this achalasia cardia. Now coming to the Hirschsprung's disease. In Hirschsprung's disease, what was the problem? There is the non-development of the ganglion itself. There is failure of migration of the neural crest. So whenever there is neural crest is not migrating properly, what is happening is there is absence of the enteric nervous system. Both the myenteric plexus and Meissner's plexus are being lost in this disease. Both myenteric as well as the Meissner's, they are not developed in a particular region. And the most common region is rectosigmoid region. Rectosigmoid colon, that is the region where it is commonly absent. There is one more reason which is said that there is a specific receptor called as endothelin B receptors. This has not been asked in MCQs, but there are chances. Endothelin B receptors. These are the ones which are responsible for the migration. So whenever these receptors are defective, what will happen? There will not be proper migration of the neural crest, leading on to the Hirschsprung's disease. So what is the only treatment? The entire segment is not functional. The entire segment is not getting ENS. We cannot supply the enteric nervous system there. So our option is to resection and anastomosis. Our option is to go with resection and anastomosis. This is the best option for the Hirschsprung's disease. So these are the two motility disorders we should remember.